So what we're going to talk about is chronic myeloid leukemia, when or can we stop treatment, which is really the whole field's gone in a circle, because probably the first patient that I spoke at on chronic myeloid leukemia, how can we get these drugs for patients and how we can get these fantastic sort of new treatments for chronic myeloid leukemia funded, and now we're looking at, well, patients are on them, is there an option to discontinue therapy? So I thought I'd take one of my patients and have a little bit, to set the sort of scene, and hopefully this may, some of you may identify this. So this was a 48-year-old woman who had chronic myeloid leukemia. She was diagnosed at the age of 42, so 6 years ago, and has been treated with Imatinib on a standard dose, and has had careful monitoring of the BCR-ABL, and went negative after 18 months on treatment and remained negative. She's got some puffiness around her eyes from being on the Imatinib, has muscle cramps, but otherwise it's reasonably well tolerated. And the question that she asked is that, could she come off the Imatinib? So is there enough information? Is this something that you could consider? And so that's really the topic that I want to discuss. I'm very happy to be interrupted and have questions and discussion as we go through. So let's take a step backwards to where this all started. So chronic myeloid leukemia is defined by this chromosome abnormality, and Ian in his talk this morning talked about how when we do a bone marrow we do chromosome studies, and the key feature, as you know, in chronic myeloid leukemia is this Philadelphia chromosome. So it's just present in the bone marrow cells, it's not present in any of your other cells, it's not inherited, it's not passed on to your children, and it is an abnormality of chromosome 9. So here's the normal 9, and here you can see this extra bit on it, and here's 22. So this is the Philadelphia chromosome. You can see it's a little bit sort of shortened, and that's because this bit of 9 is sitting here, and this piece of 22 is sitting up here. So that's the change, it's this translocation, this swapping around of DNA, of genetic material. And here it's done in a diagram form. So here's the normal chromosome 9 and 22, and it has these genes that we all have, these potential cancer-causing genes, the ABL gene and the BCR gene. But the swapping around, this bit going on to chromosome 22 and this bit of 22 going to 9, results in this Philadelphia chromosome, and it brings together these two possible cancer-causing genes, it puts them together so they become a cancer-causing gene called BCR-ABL. And what that does is it makes a protein that drives proliferation of the blood cells. So that's the underlying cause of this leukemia. And so it was a major breakthrough when drugs were discovered that could target this abnormal protein, switch it off, stop that activation of the downstream pathways, and the leukemia cells would die. And so there's a number of these drugs that can target the BCR-ABL protein. So what this tangle of or ribbons show, this is chemists in the laboratory who do crystallography, and so the blue is the abnormal cancer-causing protein. And you can just make out this is the drug, and it binds into the protein and blocks it. And so in New Zealand we have access to the original Tyrosine kinase inhibitors, the original drug used in chronic myeloid leukemia, Imatinib, and what we call second generation drugs, Nilotinib and Discontinue, and there's now some third generation drugs, Imatinib, which are in clinical trial and clinical use. So these drugs went into clinical trials, and last year the results of the first big trial, the long-term follow-up, 10 years of follow-up, was published, and this was a study that took patients with newly diagnosed chronic myeloid leukemia, and they were randomized between Imatinib or the best treatment we had, and this was in the early 2000s, was interferon. And after a year the trial got stopped, and that all the patients on interferon got the opportunity to cross over to Imatinib because the differences were so profound. And so both of these arms, the patients have been treated with with Imatinib. And you can see with 10 years is that over 80% of the patients remain well and alive and free of their were in a remission. Whereas prior to these drugs, the survival for this disease was around 4 to 5 years. We don't have any long-term sort of comparison sort of data between the new drugs and the old drugs because the differences were so profound. It was unethical to continue the study. So most studies, when you have new drug A, you compare it to B and you keep comparing it. But this would just be totally immoral and unethical to do that. So the only way we know is, well, has it, how big a change has it had on people's lives? And the only way we can do that is by looking at cancer registry data. So this is data from Sweden, where they collect a lot of information about patients, not just the numbers of patients with cancers, but what happens to them. And so if we just look at this top left-hand panel, so if you were a male in Sweden, age 55, and in 1990, is that age 55, your life expectancy was around another sort of 25 years. Whereas if at that time you were diagnosed with chronic myeloid leukemia, your life expectancy was only another 4 to 5 years. Imatinib and all of these new drugs for chronic myeloid leukemia were introduced in 2000. So now if a patient, a male, age 55, is diagnosed with chronic myeloid leukemia, the blue dotted line is for a normal male without chronic myeloid leukemia. Their life expectancy is improved because of improvement in our general health and care is around 25 to 30 years. But you can see a patient with leukemia, chronic myeloid leukemia, the life expectancy is almost identical to someone who doesn't have chronic myeloid leukemia. And the same for different ages and for males and females. So we now believe that for most patients with chronic myeloid leukemia who are treated, is that their life expectancy is very similar to that of the general population. So we've seen a revolution over the last 15 years, is that now patients with chronic myeloid leukemia, one of the tyrosine kinase inhibitors, and we abbreviate that to TKI, is standard treatment for adults and our children diagnosed with chronic myeloid leukemia. In New Zealand, we have access to Imatinib and Dasatinib, the second generation drug, is first line treatment, and Nilotinib is for second line therapy. And we use one or other of these drugs for newly diagnosed sort of patients. So, come back to the original sort of question, and the issue that the patient asked me is that you've been on Imatinib for 6 years, was in a molecular remission, is that can the drug be stopped if patients have had a really good sort of response? And the current, if you look at the research that's going on in this field, it's about stopping the tyrosine kinase inhibitor therapy. And there's a new terminology, if you go on the web, is that it's now this concept of treatment-free remission. So in the past, we were talking about response rates and depth of response. Now the research and the new trials are looking at options for, can we take patients off the drug and will they remain in remission? So why would you want to stop a drug if we've shown that it's very effective and that the survival with these drugs is very similar to the general sort of population? And there's a number of driving factors as to why you may want to stop your drug. And some of it is around the concept. Many patients tell me if they're taking their medication, that they're taking their medication, it's just a reminder that they still have an underlying sort of blood cancer. So it's that concept of a chronic illness that needs ongoing treatment versus if you come off treatment, are you cured, are you free, you no longer have to take any drugs. So there's issues around there. The second is side effects. So although we as the clinician would say, well, these drugs are well tolerated, and compared to our chemotherapy drugs, they are, but most of the drugs, Imatinib, Disatinib, they have some, I put there, what we as your doctor might call a mild side effect. You may have a different view of that, but common side effects are that retention of fluids, so puffiness of the ankles, the puffiness around the eyes, the muscle cramps, particularly in the small muscles of the hand when you're holding a pen. A small number of patients may get rashes, and most of them cause some irritation of the gut, although usually it's not as severe as with other chemotherapy. But many studies have looked at this, and they do impact on sort of quality of life. I think a bigger issue with ongoing treatment, and particularly with the newer, the second generation drugs that are more powerful, is that although we call these smart drugs because they're targeting the cancer protein that's in your leukemia cells, is that there are some off-target side effects. So they do hit other proteins as well as the cancer protein. And that's a concern because you may be on this drug for 10 years, 20 years, 30 years. And so what might be long-term side effects of treatment? We know that Imatinib, so Gleevec, the first of the chronic leukemia drugs, is relatively safe long-term. So this is the same study that I showed you, the long-term follow-up, the 10-year plus follow-up. And when they looked at 11 years of follow-up, showed the efficacy of Imatinib persisted, but it was not associated with any unacceptable cumulative or late toxic effects. So there were no long-term off-target side effects. In contrast is that the second generation drugs, Nilotinib and Disatinib, although they're more potent and more powerful, is they do have a potential for other side effects. I've just shown it here for Nilotinib, so this is the drug Tyrosine is its trade name, and this is looking at cardiac side effects. And just want you to look at this one table. So this is from the large study that compared Nilotinib versus Imatinib for newly diagnosed patients. And if you look onto this panel here, is that patients that were on Nilotinib had a 3 to 4 times increased risk of cardiac events, so heart attacks or other cardiac or blood vessel events compared to Imatinib. So there's a concern if you're on this drug for for 10 or 20 years, might it increase your risk of a heart attack? So particularly for someone who's already got risk factors for vascular disease. Another reason that people may want to discontinue drugs is that the difficulty of taking a tablet or tablets every day. As a medical professional, I have difficulty completing a simple course of antibiotics because once you feel better, you sort of think, I feel better now, I don't need to go to, yet you are on a drug that you're taking every day. There's no immediate consequences if you don't take a drug one day. There's no immediate consequences the next day, but we know that patients that aren't fully adherent to their therapy, that they have a lower response rate in terms of the depth of their response. So it is, it's not a trivial issue, taking medications on a regular basis. I've talked about side effects of the drugs on the patient, but there's also the concept these are not cheap sort of medications. And although the incidence, so the number of patients being diagnosed each day or each year around the world with chronic leukemia is roughly the same, about 1.5 to 2 patients per 100,000 population per year. Because patients are surviving, is that the prevalence, the number of patients who now are living and living well with chronic leukemia is increasing and increasing. So if you take the drugs, is that in New Zealand, when Imatinib was introduced in the early 2000s, it cost $48,000 a year. We had to, LBC campaigned on all of our behalf to get funding for that medication, because at that time that was the most expensive for a cancer drug. There are now a lot of other drugs that are pushing that up to 100,000. So in the United States is that the drug companies can continue to change the price of the drug. So in the US, when they introduced Imatinib, it was $30,000 US a year, so 50,000 New Zealand. now, at the moment, in the US, Imatinib, the advanced Imatinib, is $120,000 US per year. Okay. The generic Imatinib, which is now, for those of you on Imatinib, is that's Imatinib's now off patent, and so we have a generic Imatinib, and that's less than, in New Zealand, costs less than $5,000 a year. So huge saving of around $10 to $12 million to the pharmac budget that can go into other sort of cancer drugs. In the US, the generic Imatinib has just been introduced, but it's at a similar price. In Europe, the TKIs are estimated around $30,000 to $40,000 per year. The second generation drugs, and if you're taking those, Discontinuation and Nilotinib, it's hard to get the exact price of those in New Zealand because they're all part of confidential arrangements with pharmac, but that'd be somewhere between $50,000 and $100,000 a year for the drug. So this is a lot of funding, and particularly in countries like the US, where either your insurance company, or if you don't have medical insurance, the individual has to pay for it. It's a significant sort of issue. Just looking at it, in New Zealand, this is data from pharmac, and this is use of all cancer drugs. So the blue is standard chemotherapy, but this is the tyrosine kinase inhibitors in this green colour. And you can see most of these, there's some lung cancer tyrosine kinase inhibitors, but most of these are chronic leukemia drugs. You can see it's around $20 to $30 million in the spend per year on those drugs. So to the country, it's a significant level of funding. The final reason, which is sort of a special case in itself, is that this is a condition that affects all ages, and so often we have women of childbearing age and they decide they want to have a family. These drugs can potentially cause damage to the developing baby, and so we don't recommend conceiving while someone is taking one of these drugs or continuing it during the pregnancy. And so for a patient who's got chronic leukemia or wishes to become pregnant, is that maybe another reason for needing to come off the drugs? Not everybody though wants to come off their tablets. This is Green Abdul-Jabir. So, and this is ex-President Obama. Now, Obama is about 184 centimetres, okay, and he's struggling to put his Congressional Medal of Honor around Abdul-Jabir's neck. So he's a basketball player, famous basketball player, played for UCLA and the LA team, but has also done a huge amount for the Afro-American community and setting up trusts, and so there's been a film around him, and he's written sort of books. But he has chronic myeloid leukemia, and as a talk, he was initially on Imatinib and then got changed to Nilotinib, and has got a deep molecular response. And his clinician suggested that he may wish to sort of come off treatment, but he didn't want to come off treatment. He felt very secure on treatment, and so coming off treatment is not for everybody. And so his decision was to remain on therapy. So although I'm talking about treatment cessation, coming off treatment, is that it's not for everybody. It's an option. Are we there yet? Is this something that is on that we're doing in New Zealand? Does the data support that? So, if you're thinking about it as a patient, what are the things you want to know, and as a clinician? So, first of all, not just can we do it, and some patients remain in remission. What we need to know, is it safe to do? So if we stop it and a patient's leukemia comes back again, if we start the treatment again, will they respond and go back into remission? So, patient centered, not doing any harm to a patient is paramount. So the first thing we need to know is it safe? So if we stop a drug and the leukemia were to come back, do we know confidently, can I say to you, do we go back onto treatment, that you will respond again? Secondly, is that if we're going to stop it, does the leukemia remain in remission? If we're going to stop it, at the moment you'll all be being monitored on a regular basis. Do you need to continue the monitoring? Does it need to be more intense? How do we do that? Are there any side effects or other risks of stopping sort of treatment? Do you think stopping treatment, well, that's going to be free of side effects? Show you some data that it perhaps isn't. can you pick the best, like placing a bet at the rate, the TAB, can you pick the people that are the highest chance of responding and staying in remission? If it doesn't work the first time, it comes back, is that it? Do you have to go back on the tablets? Is there a chance of having a second stopping trial? And if I'm not quite in a group and my doctor doesn't think that I can stop because I haven't got a good enough response, is there a way I can improve my response? So, can we increase the number of patients who we can stop? And so finally, are we there yet? Is this something that's part of treatment options in New Zealand and Wellington in 2018? So this is the first trial out of now over 10 trials and 2,000 patients worldwide, and virtually all the studies look the same. So this is a study, it's the French stopping Imatinib for the study. And it was 100 patients who had been on Imatinib for their chronic myeloid leukemia for 3 years or more and had been in a deep molecular response, so complete molecular response. They've been negative on the PCR test. So the test that you have 3 monthly or 4 monthly or 6 monthly, and your haematologist will give you a level and say it's 0.01% or 0.007% or was negative. So these people have been negative for at least 2 years. They then stopped the drug and monitored carefully, and then they defined loss of molecular response as if it became positive again at any level and then was confirmed on a repeat test. So over the next couple of slides I'm going to show you, and if you're at other talks, is that as clinicians we look at these sort of Kaplan-Meier curves, and so these on the y-axis has a percentage, and it might be of duration of remission or duration of molecular response, and it's time along the bottom. So here's on the x-axis is months, so this is 5 years, and here is the number of patients that are remaining in a molecular remission, that are remaining negative on their screen. And so you can see that 40% of patients at 5 years remain PCR negative, remain in molecular remission off their drug. 60% of patients did have a molecular relapse, so they became positive again, but all of those patients responded to going back onto Imatinib, so they went back into remission again. So those first 2 questions that we posed is that, is it safe? So if I stop the drug and it becomes positive and I have to go back onto drug, will I respond? And the answer is yes, and all the studies show that. And 40% of patients remain negative, remain in a molecular remission. You always, as a clinician and as a patient, you want to say, well, that's just one study. You want to make sure that's confirmed. So here's the French study. This is a study from Australian colleagues, 40 patients, and longer follow-up, but identical results. Okay? And in fact, there are 6 studies with Imatinib for the stopping, and they all they used different definitions of molecular response. So some of a molecular relapse. So some of them just chose becoming positive again. The newer studies have allowed patients to go up to a level of 0.1%, so up to a loss of a major molecular response. But what you can see is that the results are almost identical, that about 40 to 50% of patients are remaining in a stable molecular response. So that first French study has been really repeated in ongoing studies. What about if you were on one of the new drugs, Discontinued, the trade name for that, Sprycel, or Nilotinib, the trade name to Cigna? Is that the same? And it does. So this is a study from the Japanese with Discontinued. So most of the patients have been on Discontinued after having been treated with Imatinib, and you can see this is patients remaining in a molecular remission, so treatment-free remission, and 50%, and again, almost all the relapses occurring in the first 6 months. What they did show though is that patients that had swapped from Imatinib to Dasatinib because of intolerance, this red line, that they had a better chance of remaining in remission, whereas if you had been resistant to the Imatinib, so hadn't had a good response to Imatinib, and then got swapped to Dasatinib, is that those patients had a higher risk of relapse on stopping the Dasatinib. So there's some messages there. I'm trying to think of, what are my chances of staying in a remission. Patients that are on, that have been resistant to their first drug and have changed to another drug, higher chance of relapse. Not totally out of the question, but not as durable responses. This is just, this is a slide that's turned it the other way around from the Europeans, where they've looked at the risk of molecular relapse on stopping. So it's almost the reverse of those curves like this. So this is patients that are on a second generation tyrosine kinase inhibitor, either as their initial treatment or swap because of intolerance to Imatinib, and you can see less than 40% relapse, so that means 60% remaining in remission, whereas patients that had had a second generation drug, Dasatinib or Nilotinib, after resistance or not doing so well on Imatinib, just under 80% relapse, so only 20% remain in remission. So we know we can safely stop the drug after both Imatinib and the second generation drugs. What is involved with the patient? Do you need to be monitored sort of closely? And unfortunately you do. It's more intense monitoring. And the reason for that is that if you look at this left-hand panel, this shows the pattern of relapse. So this is a patient that's relapsed. So here's the patient, here's their PCR results, so close to 100% of diagnosis. So they've started treatment with Imatinib and it's gone down to negative and it's remained negative for a long period of time. They've stopped the drug at the start of the blue bar, and here's one of the patients that's had a molecular relapse. And you can see it happens quite quickly over a period, this is in months, of a period of around 6 months, whereas this is patients, the rare cases that have late relapses, they're much slower, they happen over 12 to 18 months. So because the relapses occur early and they occur quite quickly, is that the guidelines for monitoring are quite intense. So if you're going to stop treatment, is that we need to do regular monitoring at least every month for the first 6 months, because we want to kick that, we don't want to suddenly find that it's gone from negative to 1%. We want to get it early. Well, hopefully we're not going to see it at all. And so these are different. This is Australian guidelines, monthly for 6 months, then 2 monthly or quarterly for the next 6 months, and then quarterly indefinitely. This is the US National Cancer Institute, monthly for 6 months, 2 monthly, months 7 to 24, then quarterly indefinitely. This is European, monthly for 6 months, then 6 weeks for the next 6 months, and every 3 months after that. So if I'm going to stop a patient, I need to be confident, and between us we need to have a discussion that it's going to be that regular the regular testing. So there's a commitment. So some of the patients I'm discussing it with, they're travelling a lot, and so we've made a decision to defer it until there's a time when they're going to be more stable and we can do that regular monitoring. Are there any other risks? So coming back, if you do in that group of 40 or 50% that have a relapse, if I go back onto treatment, I'm going to respond, and as I showed you from the French study, yes, all patients respond. And this is just a slide. Here's patients that had relapsed on stopping Nilotinib, and they went back on Nilotinib, and you can see that fairly quickly, this is in weeks, so somewhere 12 to 24 weeks, patients, 100% of patients have gone back into remission. So we know that it's a safe thing to do. We can stop it. We know that if you we're unfortunately in that group that had a molecular relapse that we can go back onto the treatment. The other issue that we always need to talk about is that there's a new syndrome being described called TKI Withdrawal Syndrome. You think stopping a drug, that's good, I'm going to feel better, I won't have the muscle cramps. So this has been described, and we've seen it in the patients that we've discontinued, and so it usually occurs in the first couple of months after stopping, and it's sort of an arthralgia, but like a polymyalgia, so pain around the sort of hips and shoulders, so a mixture of muscle and joint pain. The studies say that it's mild, and patients usually just need to take some paracetamol or non-steroidal like Voltaren or Brufen, and it goes away, usually in 6 to 9 months. Our experience is that, that I've had some patients that has been a little more severe and has often gone on up to 9 to 12 months, but it has, in all our patients, has resolved. It's often patients have got some background arthritis, so it's been on a background of that. We don't know what the mechanism is. It doesn't relate to the depth of the molecular response, so it's unusual, it's totally unexpected, and I think it's something that needs more work on, but it is there, it does occur. Can I give you some advice around, what are your chances of staying in remission? So can we pick the winners, so helping you make, if you're thinking about it, making a decision. So the longer you're on your Imatinib, your Gleevec, or your Nilotinib, the better. So, the study showed if you're on for 5 or 6 or even 8 years, you've got a better chance of remaining in sort of remission. The depth and duration, particularly the duration of being in a deep molecular remission. So if you've gone negative, the longer you're negative, the better the chance of staying in remission. And so this was a study from the Europeans, the EuroSTI study, is that patients that have been in a deep molecular response, so negative for more than 2 years versus less than 2 years, the chances of remaining treatment-free, nearly 80% versus 15%. So hanging in there and having a longer treatment and being in a deep remission for a longer period of time increases your chances of staying in remission. And the early studies also suggested SoCal is one of the clinical risk scores that's based on your spleen size, your blood cell counts, and so it's a clinical scoring system. So patients that have a lower clinical risk score, this suggestion that it might be a better predictive factor. If you have a trial and it comes back, you have a molecular relapse, what happens then? So here's a patient pathway. So diagnosis of CML, starting Imatinib, good response, a trial of stopping treatment, but unfortunately a molecular relapse, restart treatment. At the moment, patients are going on to back onto treatment and probably lifelong treatment. But it may change in that there's a number of clinical trials underway at the moment looking at second attempts at stopping treatment. So restarting the same drug and having a second attempt, you think, well, gosh, if it came back the first time, why would a second time on the same drug? And that's sort of what the data is showing. What about changing to one of the more potent drugs, get an even deeper response? So that trial is underway, we don't have any data on that as yet. Or adding in another drug, putting 2 drugs together, or doing something else, so add-on strategies. So don't feel, if you do have a trial of stopping and it comes back, don't think this is my life is going to be taking this. It's a field that's moving, the studies are ongoing. But at the moment, a second trial of stopping would only be as part of a clinical trial as of today. What about if you're not in a deep enough response, you haven't gone negative or nearly negative? At the moment, again, we've got the diagnosis, starting treatment, not a deep response. So our patients are just staying on their lifelong Imatinib or Dasatinib. So is there any option, can you get me into a position where we consider a trial treatment? And so there are studies underway of switching, even though you've got a good response and reaching all the targets that your haematologist has set, can we change to one of the second generation drugs to get an even deeper response and have a trial of stopping drugs? Or again, can we do an add-on strategy, add some novel therapies? These are all part of sort of clinical trial, so it's not standard of care as yet. But I think the field's moving, so I think even if you're not someone who's negative or nearly negative at the moment, it's I think there will be options in the next few years. If you come off drug and you stay in remission, are you cured of your leukemia? And it's a funny word. What does cure mean? And because we've got these tools where we can detect leukemia cells down to lower and lower levels, down to 1 in 100,000, 1 in a million. We don't think patients are cured, which is why you need, even off drug, to stay on regular monitoring. And this is a single patient from the French A-STIM trial where they used a lower level of molecular relapse before restarting treatment. So in the original study, anyone that was negative and then became positive, confirmed on a repeat test, was called a relapse. The A-STIM trial allowed patients to go up to a level of 0.1% before calling it a relapse. And you can see here's a patient that's still got low level of disease going up and down. They haven't relapsed, they're still off drugs. So I think there's still very, very low levels of the leukemias that are sitting there. So it depends what you consider a cure. So come back to the question that we asked, are we there yet? So in September 2018, do we have it? Is that data that I've shown you, is that enough to convince clinicians who are conservative, because our primary goal is first do no harm? Do we have enough data to start offering and discussing discontinuation? So 2 years ago, there was 2 editorials appeared in competing journals. So this one from Australian colleagues in the journal Blood, which is an American journal, and moving treatment-free remission into mainstream clinical practice. They were advocating there was enough data to move, to be considered as part of treatment. This appeared in the journal Leukaemia from French and German sort of collaborators, and the concept of treatment-free remission, and they were still saying it should only be done as part of a clinical trial. In the 2 years since there, is that we've now got over 2,000 patients on over 12 different clinical trials. The data, those curves are almost all the same. We know it's safe. We know that patients who have a relapse will respond to reintroduction treatment. So now it has moved. We are there. And it's starting to appear in guidelines for clinicians. So it's in the US NCCN guidelines, there's recommendations around discontinuation. So we've got quite a conservative approach in our centre in Auckland. So for patients with the chronic phase, so we wouldn't consider stopping drug in someone with accelerated or advanced disease. A first line TKI or second line due to intolerance. So we wouldn't, if someone had had resistance to Imatinib and gone on to Nilotinib or Dasatinib, we would be hesitant to recommend discontinuation. We like a longer duration of therapy, so over 6 years on Imatinib or Dasatinib or Nilotinib, and in a complete molecular remission, so negative testing for 2 years, and a molecular monitoring is monthly for the first 6 months, 6 weekly for the next 6 months, and then 3 monthly thereafter. And our definition of loss of response is a level of 0.1%. And with that, we estimate that we should be able to, about 60 to 70% of patients should remain in a stable treatment-free remission. So the concluding and final slide is that I I think we are there. I think it's an option for patients. I think each hospital, each clinician needs their own guidelines, so they may vary around. There'll be similar concept, and they may just vary as to whether it's 5 years or 6 years or 4 years of treatment. I don't think it's a rush decision. I think this is something that needs, it's not just you come in and say, oh, today's the day I'm going to do it, and you stop. I did have one patient who had the discussion, and they went home and decided they would sort of do it, and I was just sort of introducing the ideas, and then suddenly sort of saw that she was having monthly tests and had sort of already done it, and it sort of wasn't quite how it intended it. So I think it's sort of I think it's something that it's patient power, I think. But I just think it's something that needs probably over 2 to 3 appointments, just that bit of discussion, because not everyone needs to do it. It's, I think there's the benefits and risks need to be discussed, and I think there needs to be a careful plan in place for the monitoring, and then the definitions are, if it comes back, what level we're going to restart treatment again, and what treatment we're going to give. So that's why I see treatment-free remission. As I said, it's the hot topic in chronic myeloid leukemia at the moment, is where the trials are all looking at either how can we get more patients into being able to stop treatment, and collecting ongoing data around those that discontinue treatment, learning more about this new TKI Withdrawal Syndrome, which you as the patients thinking about this, that's where we're gathering the data from.